Thank you, guys. It's a pleasure to be up here with you guys today. Uma and David, thank you. David, a joy not to be debating you this year. I think I'll probably be able to keep my 0-6 record intact today. We'll see. Miguel, I'm going to go really slow. I don't have my sock puppets to help out, but I'll just go slow. You interrupt if there's any issue here, and we'll be able to get through this. This is the title that I was given to speak about. Con, an IBD patient on a biologic and/or an immunomodulator who develops a malignancy, solid tumor, lymphoma, or skin cancer, must stop and never restart these medicines. And that's a pretty bold thing. I do have some disclosures that might be relevant, and it's important to keep that in mind. Miguel didn't show you his, but I guess they're somewhere. And here's what we're not asking. We're not asking if these medicines are efficacious or not in IBD, and we're not talking about safety in general for IBD patients. And there are really many ways to look at this whole cancer and IBD situation. And there are many, many ways to look at it. The first thing that we can consider is whether medical therapy for IBD predisposes to the development of cancer. And Miguel spent a lot of his time talking about skin cancer, including the skin cancers we don't care so much about, particularly here in Florida, where everybody's out there in their bathing suits outside, all oiled up, trying to get a tan and promote these skin cancers that aren't really quite as clinically significant as the other things we're talking about. Miguel spent about half his time talking about squamous cell carcinoma and basal cell carcinoma. We know that these medicines are associated with a risk, but that's really not what we're talking about here today. We're also not talking about what to do once cancer develops in an IBD patient. Is the cancer therapy or outcome any different? And that's pretty important, and we'd like to have a better feel for that, but that's also not what we're talking about today. We're also not talking about whether in an IBD patient with an active cancer, does cancer therapy affect IBD outcomes? Very important question. All of these questions are important, but not what we're talking about. What we're asking here is if a malignancy develops while on IBD therapy, is it ever safe to restart that agent that led to, or perhaps was just associated with, the development of that malignancy? So here's what we know from the renal transplant world. In this study about patients who are on immunosuppression for their kidney transplants, 823 of them, there was a really extraordinarily high rate of cancer recurrence for patients who had a prior history of cancer. There are some kinds of cancers that are presumably low risk, some that are intermediate, and some that are high risk. And certainly among them are the ones that we should be caring about most: bladder cancers, sarcomas, the melanomas that Miguel very bravely has put some patients back on, myelomas, and then obviously renal cell carcinoma, big concerns. But the kind of immune suppression we're talking about is not necessarily the same immune suppression we're talking about within IBD. Fortunately, we have some guidelines to help us out in the case of ECHO, but no guidelines to help us out from ACG and WGO. But the ECHO guidelines are pretty clear, at least, and they say that anti-TNF therapy is contraindicated in patients with a history of lymphoma, and careful consideration should be given to initiating anti-TNF therapy in those with a history of a non-hematopoietic cancer. So we've got to be extra cautious when we're looking at these patients. There are black box warnings that are all over things like the Imuran package insert that's there, risk of malignancy in humans with antimetabolite therapy. Thiopurines are contraindicated for patients with rheumatoid arthritis that are previously treated with alkylating agents. Shouldn't get Imuran in that situation. And it's also important to point out that when we go to our clinical trial data that's out there, we have to be very, very careful because it's almost always an exclusion criterion. If you've had a malignancy within your last 5 years, you can't get into these trials. As a result, these data don't help us whatsoever. We can't even go to the safety data from our clinical trials. And as a result, the package inserts or prescribing information that goes along with these agents reflects that fact. Right? Caution needs to be exercised in dosing infliximab for patients who have been previously on an anti-TNF, previously had a malignancy. It's out there for adalimumab as well. It's there in the certolizumab data or certolizumab prescribing information as well. So we have to be extraordinarily careful. There are real limitations to the existing studies. What we have to look at when we're looking at these issues that we're looking at, what to do when a patient develops a cancer while on one of these agents, we're really limited to observational registries and all of the problems that go with those. Most guidelines, as I mentioned, really are quite restrictive in this regard, and we really have almost no data to base these decisions on. So what do we have? Well, we have the SESAM cohort, and thankfully Miguel has already brought this to your attention, and there was no risk of subsequent cancer in the almost 20,000 patients who were enrolled in these studies in the mid part of the last decade. So while we say that, it looks as though there might be some sort of signal that's going on here. New cancers seem to develop in those who are immunosuppressive therapy naive at a slower rate, it seemed, than those who were not. And so we've got to be a little bit careful here. The British registry was very, very interesting in this study by Dixon. 14,000 patients with rheumatoid arthritis, 293 of whom had had a previous malignancy. And it turns out that if you went on to a DMARD, you did pretty well. And if you went on to an anti-TNF, it appeared that you might have done better from the perspective of whether or not you would go on to develop a subsequent malignancy. These are about as good data as we have, by the way. But the problem is that based on the British Society guidelines that were out there, the British Society for Rheumatology guidelines that were out there, patients who had had disease, had their malignancy within the last 10 years, were much, much less likely to be placed on an anti-TNF. So these data, again, are biased, and we really have nothing to base our decision on. The German registry that was out there showed the reverse, which was kind of interesting. Prior malignancy in 122 out of the over 5,000 patients who were there. 58 received anti-TNFs. 55 of these prior malignancy patients received DMARDs. 14 were exposed to anti-TNFs with 15 recurrent cancers. And it looked as though numerically here, your rate of developing a cancer recurrence was substantially higher, 45.5 per 1,000 patient years in the anti-TNF group and only 31.4 in the DMARD group. And the incidence rate ratio was a fairly impressive 1.4, but as you'll see there, it didn't meet statistical significance. 122 patients just wasn't enough to make the difference. So there's a lot of confusion out there. We don't really know what to do. I can debate a point here. Miguel can debate a point here. We'll have a nice little panel discussion when we're done. But really, there are no data to guide us. And this group of authors, and I'm the middle person in this, and therefore the person who really offered the least to this group, and that's the truth. But we took a look at this. We took a look at these data that are out there, and what should the management of immunosuppression in patients with IBD and cancer be? And there's just not a lot of data out there, but we did come up with this clever algorithm, or at least I think it's a clever algorithm. And even with the monitor so close to me, I'm having trouble reading. But if the cancer is controlled, that's a nice thing. And you can then consider restarting, we arbitrarily said, after 2 years. Miguel was a little more aggressive. I think you had 1 year up there on your approach to it. I think that we could, there are no data to guide us, but I think that that's a way that we can move things forward here. If the IBD is controlled or not is a huge part of the decision-making here. If the IBD is well controlled, you don't have to worry. You just continue to follow what's going on. If it's not well controlled, then you can think about being a little bit more aggressive. If you're beyond 2 years, you can do a step-up approach with therapy. You can bring in anything that you like to. But if the cancer's not well controlled, or if it's too recent, you need to hold your immunosuppressants. You need to really be sensible about this. You need to talk to your cancer surgeon. You need to talk to your oncologist. And you need to be pretty wise about this. If the IBD turns out to be controlled, then you can just continue on the course that you're on. But if the IBD is uncontrolled and the cancer is not really particularly under great control, then you have to pull the trigger and really have a nice patient-centered discussion, include the patient in this, and then probably go ahead and proceed with giving some therapy very, very cautiously. So our recommendations are a multidisciplinary approach to the safety of this depends on cancer type, depends on real risk of recurrence in the natural history of that cancer, and really depends on the risk of IBD activity and what's going to happen if you don't give the medicines next. And we conclude, manage the IBD patients with past or current malignancy. It's an increasingly common problem. In fact, it's occurred to me 3 times this week, including once last night without resolution. There are few studies that have been done in our IBD population. We're really all flying by the seat of our pants on this issue, as we are by so much with so much else. You need to use caution with the thiopurines if the cancer therapy is going to produce any kind of bone marrow suppression. And we have to have some fear of using anti-TNFs in patients with a current cancer because we just don't know, and the decisions really need to be made on a case-by-case basis with an oncologist, with patient awareness and preferences taken into consideration. And I've shockingly left some time on the table so that we can discuss this in a more intelligent fashion than our debate. I'm no Perry Mason up here. I've lost to Rubin 6 times. They won't even let me debate him anymore because it's just gotten too boring for the CCFA. I plead for mercy, and thankfully we didn't have the voting first. We'll only have the voting after, or perhaps not. But I look forward to our panel discussion on this. Thanks.